Hi guys, good evening. Good evening. Can you all hear me? Can you all see me? Hi Osama, good evening. Right, so we'll continue from where we left off yesterday. कल हमने बात की थी in terms of the burns. How do you classify based upon the burn wound depth? What are the criteria that you look into it? कैसे पता चलेगा कि are you looking at a superficial burn that is a first degree, second degree superficial, second degree deep, or a third degree burn? Now, if I keep everything जो भी हमने कल पढ़ा था, if I give you an algorithmical manner, like that means how you actually interpret it as we go forward. So we'll try to understand in a protocol based approach. Same thing, the burn wound assessment depth. So the first thing, as soon as the patient comes to you, we say, look at the burn. The first thing you do, it is to look at the burn, right? Now, what are you looking for? You're looking whether the epidermis is involved or it is going to be for a deeper tissue involvement. So, here you're going to see is the integrity of the epidermis maintained or not, right? So, we say the epidermis integrity. Epidermal integrity, the epidermal integrity, is it maintained or not? Now how do you assess the epidermal integrity? कैसे पता चलेगा कि epidermis intact है कि नहीं है? In order to understand the epidermal integrity, we have a sign. ठीक है, your dermat guys would have told you multiple times, so I'm just going to mention it across. There's something called as the Nikolsky sign, right? What is this Nikolsky sign? So we say Nikolsky sign, it is basically whether the epidermis, which has been separated, so is it an epidermal separation is present or not? That means Nikolsky sign basically tells you that the superficial part of the epidermis has given away. So how do you do a Nikolsky sign? You just gently put the hand on the skin and then you try to rub it off. If you rub it off and if the skin peels off, that means if the epidermis peels off without having any resistance, we call it as Nikolsky sign positive. If I just show you the image of what I mean by this. So this is what we call it as a Nikolsky sign positive. You can see that I'm gently going to rub my hand and without having any pressure, without having any resistance, the skin will directly give away. It will directly peel away, and this is what we call it as the Nikolsky sign positivity. Okay? So as soon as the patient comes to you, you look at the burn. In the burn, I'm going to look for the epidermal integrity. The epidermal integrity may be maintained, or I can say the integrity of the epidermis is actually assessed by Nikolsky sign. ठीक है, अगर Nikolsky sign positive है तो we say the epidermal integrity is maintained. That means the burn has not gone into a deeper layer. But if it is not maintained, that means if there is, if not, so it's already burnt out, right? The underlying component has been involved. आपको देख रहे हो कि it is even more thicker or the more depth is involved, then it is going to be for a deeper discussion, or I can say the burn is of deeper nature. So when we say the epidermal integrity, which is evaluated by the Nikolsky sign, we say if the Nikolsky sign is positive and we say the epidermal integrity is maintained, I can say the burn is confined to epidermis. So I don't need to worry. I don't need to worry. On the other hand, the epidermal integrity is lost. If the epidermal integrity is lost, rather than say Nikolsky sign positive or negative, I'll say that epidermal integrity is present or it is lost. That is, no, it is not there. Now, if the epidermis integrity is lost, that means as I swipe my finger, you see the skin peeling off. That means the integrity of the epidermis is lost. We say the Nikolsky sign has been demonstrated here. Now, if the epidermal integrity is lost, what are you going to do? I'm going to put on a glove and then I'm just going to gently run my finger. That is, I'm going to wear a glove, put on the wound and gently rub the wound with my finger, right? So this is what you call is run a glove over the finger. I mean, say over the burn surface area, right? Run a gloved finger Run a gloved finger over the burnt surface. Over the burn surface. Now, as you run your finger, you'll see whether it is slippery or not, right? So what am I looking for? Is my finger able to slip or not? So is it slippery or not? That means, is my finger able to slip easily or is there any resistance, right? So I'm evaluating in the form of slippery, whether it is going to slip easily or not, right? So we say yes, it is going to slip. No, it is not slipping. I can have only two answers. Yes, it is slippery. No, it is not slippery. If it is slippery, then you will see, obviously we'll look up for blisters. So if it is slippery, I'm going to look for blisters. Usually you see the blisters are going to be present here. Now blisters can be divided into two components, the thin walled and thick walled. You have the thin walled blisters and thick walled blisters. You have a thin walled and a thick walled blisters, right? So how do you know thin walled? You can see it is going, you can see the fluid under beneath is quite visible. It is evident. You are able to see the fluid. The fluid is visible basically, and it is very thin. It pops out also. Thin walled, usually they get popped. When I say popped, they usually burst open. They usually burst open. If that is the case, they can safely say that you are dealing with superficial dermal burns. You are dealing with a superficial dermal burns. You're dealing with superficial dermal burns. If it is a thick walled, then I say that this is your mid dermal burns. This indicates they are mid dermal burns, right? So along with that, you can other signs you have, like you can, there will be a reddish base, there will be darker in consistency, it will have some amount of motting, all that other features are going to be present, but mota, this is what you're going to look across if it is slippery that is present. Now imagine you're trying to rub your fingers and this is not slippery. I'm just going to shift the base towards this side bit. Okay. Now, you try to run your fingers and it is not slippery. Now, if it is not slippery, then you have to evaluate the burn color. You would look for the burn color. So what is the color of the burnt area that you're looking at, right? On the assessment of the burnt color, you will say whether it is reddish or whether it is whitish in color. So whether it is red in texture, that is erythema, or whether it is in shades of white. If the color is red, then the answer here, it is going to be deep dermal burns. This is going to be a deep dermal burns, right? Now, if the burn color is white, then it is a full thickness burn. Then it is a full thickness burn. Now you see, when you look at all these components, another very interesting way to differentiate which is the depth of the burn, we simply look at the component of pain per se, right? Epidermal burns, or the burn if it is epidermis in involvement, it will be severely painful. Your superficial dermal burns will also have severe pain. Mild or the mid-dermal burns is also going to be associated with pain. Deep dermal burns usually do not have pain, but they have something called as the pin prick sensation. There's something called as the pin prick sensation, which is usually seen. Full thickness burns remain painless. They remain painless, right? Now, if you look at the entire algorithm of the discussion that we have, we'll have a quick recap of what we actually spoke about it. So yesterday in our lecture, we discussed that how do you know what is the depth of the burn. We had various categories or various criteria to look into it. I have simplified that in an algorithmical manner, that how do you approach a patient of burn, in order to differentiate and discuss whether you are looking at what depth of the burn it is going to be involved. So look at the burn first and then look at for the epidermal integrity. The epidermal integrity is looked with the Nikolsky sign, is positive or negative. Nikolsky sign positive is you take your finger, you swipe it, the skin peels off. It peels off without any resistance, just comes off. But you are not supposed to exert any pressure. Gently put your finger and just swipe it. While swiping it, if the skin comes off, it is called as Nikolsky sign positive. That means you have lost the epidermis integrity. And if there is no epidermal integrity, you have to judge for the further component. But if the Nikolsky sign is negative, that means the epidermal integrity is maintained. That means the depth of the burn is only limited to epidermis. It has not gone anything further. If the epidermal integrity is lost, I will examine the burn wound. Now what do? Wear a glove, take a glove finger and put on that area of burn and see and swipe your finger. See whether it is slipping or not. If it is slippery, that means you put and it goes away, that means it is going to be associated with blisters. And there are two types of blisters, the thin walled and thick walled. Thin walled, they usually pop, they are thin, you can see the fluid under beneath. Thick walled are darker in color, you cannot see the fluid which is collected inside it. They have mottled appearance and they have other features, they have red base and all that. Thin walled ones are usually superficial dermal or the superficial dermis burns, whereas the thick walled are mid dermal burns which are present. If it is not slippery, that means it is resistive, you're not able to slide your finger. Then you look at the burn color. If it is red, it is deep dermal. If it is white, it is your full thickness burn. And this will ensure that you know which type of burn or which is the depth of the burn that you're usually assessing for. Now this looks like an extensive table initially, but when you look at it, there are a lot of things that can be covered. And when you're working in casualty or let's say in the burn ward, this gives you a nice component to pick it up. So everything that we are going to learn, we'll put it in these manners so that it is going to help us in both exams. It is going to help us in our ward rounds. It is going to help us in our day-to-day patient care, and everything will be in an algorithmical fashion. Okay? Chalo. So once you have dealt with all this, now comes a very interesting component, and that is going to be our resuscitation protocol, right? So we will be talking about various components of the resuscitation protocols. Let's go ahead. So talk about the burn resuscitation. Now, one of the most interesting and important topics that you should be knowing it. So we're talking about the burn fluid resuscitation. Now, when you talk about the burn fluid resuscitation, now, in a burn fluid resuscitation, what is the fluid of choice, right? Now, this has been asked in multiple competitive exams, and this is something you should know in your ward also. So when you say the fluid of choice, the fluid of choice is going to be Ringer lactate, or you can give the Hartmann's solution. If you want to know the exact difference, they are almost similar, but if you want to know the exact difference, you can refer back to our lecture in shock where we've spoken about various kinds of fluids and their compositions. That is going to help us across. So yes, the fluid of choice is going to be Ringer lactate or the Hartmann solution. Now, how much quantity should be administered? What is the period of administration? All these are important, right? Now, initially when we started the burn fluid resuscitation, we had something called as the Parkland formula. Now, according to the Parkland formula, it says you have to take 4 ml per kg per percentage of total body surface area burnt. So whatever is the total body surface area burnt, 4 ml per kg into the percentage total body surface area burnt is what you're looking as the Parkland formula. It has been found that whenever you're resuscitating a patient of burns, under resuscitation is somewhat acceptable, over resuscitation is not, because in over resuscitation you cause fluid overload, and fluid overload is going to cause a lot of stress on the heart. It can result in pulmonary edema, hence worsening the condition, which is going to be even more deteriorating. So now we understand that over resuscitation should not be done, especially when you're looking for the burn resuscitation. So currently, with absolute authority, I'm going to say that Parkland formula is obsolete. We do not follow this any longer. So for the burn resuscitation, Parkland is out of the picture. So you would say, so what do we follow? So currently what we follow is our ATLS protocols. So we have ATLS burn fluid resuscitation. So in the ATLS burn fluid resuscitation, what are you looking at? In an ATLS burn fluid resuscitation, it says rather than trying to give a random number, let's categorize based upon the depth of the wounds or the burns that we have. So we remember we had the first degree burns, we had the second degree burns, we had the third degree burns, the fourth degree, which is more deeper involving the underlying structures, or we can also see special burns like electrical burns, right? So ATLS says that we are going to categorize the burn into 4 different degrees. Everybody knows the first degree is going to be involvement of epidermis, second degree is going to be involvement of dermis, the third degree is the full thickness, the fourth degree is involvement of underlying structures. So we have put according to this. Now it says if there is a first degree burn, all that you have to give is oral fluids. And it should be more than enough for the patient. So you don't need to worry about it. You don't need to go and resuscitate the patient, especially if the percentage of the body surface area burnt is less than of 15%. Now, if it is a second degree or a third degree burn. Now, in a second degree or a third degree burn, I would see that whether I am addressing a child or an adult. Whether I have a patient who is a child or does it categorize into adult. According to ATLS, a child is considered to be age below 14 years. Adult is considered to be age above 14 years. It is not a standard age of 18, right? So ATLS considered the adult and child in the age group of 14. That means a child is age less than 14, adult is age more than 14. It's as simple as that. Now, if you have a patient who's a child, for a child, ATLS says it should be 3 ml per kg per percentage of total body surface area burnt, right? On the other hand, for an adult, it is going to be 2 ml per kg per percentage of total body surface area burnt, right? If it is a neonate, for the same category, if you have a patient who is a neonate, for a neonate, it is going to be 3 ml per kg per percentage of total body surface area that burnt, plus I am going to add the maintenance fluid to the list. So I'll calculate whatever is the required maintenance fluid and I'll add this to that fluid and then resuscitate the patient, right? So this is with respect to second degree or third degree burns. In a fourth degree or an electrical burns, no matter if it is a child or an adult, right? It has to be 4 ml per kg per percentage of total body surface area burnt, right? So these are the formulas that we are now currently following for the resuscitation of burn fluids, especially when you look at the ATLS protocols. Now, to give you an idea about it, I'm going to take a couple of example questions and then we'll talk about the administrative protocols as well. Now, the question is, imagine I have a 45 years old male presented with 30% of the total body surface area burnt, measuring or weighing 70 kilograms, and when you assess, it is a fourth degree burn. So question will come with this information. You have a 45-year-old male with 30% of total body surface area burnt, 70 kilograms of weight, and fourth degree burn. How are you going to move for this? Now, when you look at this, the first thing, which is saying 45-year-old, it is going to tell me that it is an adult. Okay, so age is going to be important for that. Sex does not matter, male or female, it's okay. I have the percentage of total body surface area burned, that is your 30%. I have the weight which is required to calculate, and this is the most important one, the degree of the burn. Because this is going to tell me what am I going to use. Am I going to use 2 ml per kg, 3 ml per kg, or 4 ml per kg? It's a 4 degree burn. For a fourth degree burn, we all know the formula. For a fourth degree burn, it is going to be 4 ml per kg per percentage of total body surface area burnt. If I substitute these values, what do you have? I have 4 ml per kg per percentage of total body surface area. It is going to be 4 ml, 70 kilograms, 30% of the total body surface area which is burnt. Now when you calculate this, how much it is going to come down to? It is going to come down to 8,400 ml of Ringer lactate, right? It is 8,400 ml of Ringer lactate that we are going to get across here. Now, once you have this much amount of fluid, how do you administer, right? So the administration protocol. You have the fluid administration. The fluid administration protocol. Now, according to the fluid administration protocol, whatever burn fluid that you have calculated, that means the fluid which is there, 8,400 ml, this is what we call it as the burn fluid. That means this is the fluid that I am going to give the patient for resuscitation. Whatever amount that you have calculated will be considered as burn fluid. Now, fluid administration protocol says that whatever burn fluid that you have calculated, the entire burn fluid must be administered. It must be administered within 24 hours of resuscitation. So within 24 hours of starting a resuscitation, you should start giving the patient the burn fluid. Okay. Now if you look at this, you have 8,400 ml of fluid that has to be given in a 24 hours period. So what we do is we split them into two equal halves. When you split them into two equal halves, you get 4,200 ml as one half, and this is the 4,200 ml as the other half. So I'm going to abbreviate this. This is the first half of the fluid, and this will abbreviate as the second half of the fluid. So I've given the first half and the second half of the fluid, right? Yes, the Hindu doctor, you are absolutely correct. So once you have calculated this, the first half which you have calculated, that is your 4,200 ml that you have calculated, this has to be given as fast IV. And the 4,200 ml, that is second half, should be given as relatively at a lower pace. So we'll say a slow IV. Now, as the protocol says, whatever you have calculated should be given within 24 hours of resuscitation. So in order to achieve this 4,200 ml will be given within the first 8 hours, and the next 4,200 ml will be given in the leftover time, that is in the next 16 hours. So together you see within 24 hours, I have completed the resuscitation. Right? So this is the resuscitation protocol, that whatever fluid that you have calculated, that should be given in the first 24 hours of resuscitation. So whatever total fluid that you have calculated, we split them into two equal halves. The first half will be given as fast IV, will be administered within 8 hours. The second half will be given as slow IV, and that should be administered in the subsequent 16 hours. So entirely, so you can see within 24 hours of resuscitation, I am able to complete the entire fluid resuscitation protocols. I'm able to complete the entire fluid resuscitation protocols. Okay? Now here's an important thing. Fine, you're done with the first 24 hours. You're given this much amount of fluid. Let's say even after 24 hours of resuscitation, patient still requires the fluid. I cannot continue to give 8,400 ml. If you look at a basic concept of this, you need to understand the circulating volume is 5 liters in the body, and you're giving 8,000 ml. So you're already causing a lot of dilutional status. Okay? So I don't want to worsen it. So how do you take it after 24 hours, right? So after 24 hours, that is after 24 hours of resuscitation. After 24 hours of resuscitation, we see whether the patient is stable or unstable. Right? So post 24 hours, there are a lot of ifs and buts in there. If the fluid requirement is still there, if the fluid requirement persists, normally we will go ahead with something called as the maintenance fluid. We'll go ahead with maintenance fluid, that is after 24 hours. Now, how do you calculate the maintenance fluid? The maintenance fluid is calculated with a rule of 4, 2, and 1. Now, what is this 4 to 1 rule? What is this 4 to 1 rule of the maintenance fluid? Now, the 4 to 1 rule of the maintenance fluid says that whatever is the body weight that you're looking at, right? Now we'll take our patient's example only. We had a patient who was of 70 kilograms. Now the 70 kilograms patient can be written as first 10 kilograms of the body weight, the second 10 kilograms of the body weight, the rest of the body weight is 50 kilograms, right? So this is the first 10 kilograms. This is the second 10 kilograms in the body weight, and this happens to be the rest of the body weight. It is the rest of the body weight. This is the rest of the body weight. Now 4:1 rule says the first 10 kilograms should be given as 4 ml per kg. The second 10 kilograms should be given as 2 ml per kg. And the rest of the body weight should be given as 1 ml per kg. The rest of the body weight should be given at 1 ml per kg. Right? So when you look at this, 4 ml per kg for the first 10 kilograms will come as 40 ml. 2 ml per kg for the second 10 kilograms will come as 20 ml. 1 ml per kg for rest of the body weight according to 50 kilograms will come as 50 ml. So when you add all this, you will get 110 ml, and this is given per hour. This is given per hour, and this is how you're going to calculate the maintenance fluid, right? So these are the protocols for your maintenance fluid. Now, let's give you another example so that you're even better at this. If you have a 60 kilogram patient, what will be the maintenance fluid? If you have a 50 kilogram patient, what will be the maintenance? If you have a 30 kilogram patient, what will be the maintenance? And if it is a 50 kilogram patient, what will be your maintenance, right? Now in 60 kilograms, I can say the first 10 kilograms of the body weight, the second 10 kilograms of the body weight, the rest of the body weight will be 40. For 50, I'll write first 10 kilograms, the second 10 kilograms, rest of the body weight will be 30. 30 kilograms, first 10 kilograms, the second 10 kilograms, rest of the body weight is also 10. In the 15 kilograms, the first 10 kilograms, next I only have 5 kilograms, rest of the body weight will come out to be 0. As simple as that. Now if you take that into consideration, and you look at this, the first 10 kilograms will be 40. The second 10 kilograms will be 20. The rest of the body weight is going to be 40. So this is going to come to you as 100 ml per hour. So if you have a 60 kilogram patient, I will give 100 ml per hour as the maintenance fluid. If you have a 50 kilogram patient, the first 10 kilograms is again 40 here. The second 10 kilograms is 20. Rest of the body weight is going to be 30 here at the roll of 4 to 1, right? That's what we're following. So 40 plus 20, 60, 60 plus 30 is 90. So this is going to come out as 90 ml per hour. Now if you have a 30 kilogram patient, first 10 kilograms is 40 ml, second 10 kilograms is 20 ml. Rest of the body weight will also be 10 ml, 1 ml per kg. So this is going to come as 40, 20, 60, 60 plus 10 is 70. So it is 70 ml per hour. This is going to be 70 ml per hour, right? That is for the 30 kilogram patient, right? Now, if a 15 kilogram patient, this is tricky because first 10 kilograms, 4, that is 40. Second, it is 2 ml per kg. This will only come down as 10. That is 2 into 5 is going to be 10. And this will be 1 ml per kg. This is 0. So here, how much? 40 plus 10 is 50 ml per hour. This is going to be 50 ml per hour, right? So this is how you're going to calculate the maintenance fluid after 24 hours in the burn patient, right? So this is the criteria for calculating the maintenance fluid. Now another interesting thing is, even after giving maintenance fluid, if the patient is not able to maintain the circulatory status, then what can you give? Now because I cannot give large volumes of crystalloids, I have another option that is called as the colloid resuscitation. It is the colloid resuscitation. Now, whenever there is burns, basically it is going to cause a lot of inflammatory response, and inflammation will cause endothelial injury, and the endothelial injury will cause leaky endothelial capillaries, and those leaky endothelial capillaries will cause the proteins to go from intravascular space to extravascular. There will be shift in the oncotic pressure, right? Now, if you want to do a colloid resuscitation, the ideal time for colloid resuscitation is after 12 hours of burn. So within the first 12 hours, I will not give colloids. The colloid should be administered only after 12 hours, right? Now, how long can you administer it? Remember, you can administer for 36 hours. And what is the best way to calculate it? You have something called as the Muir and Barclay formula. What is this Muir and Barclay? Muir and Barclay says it is going to be 0.5 into weight of the patient in kilograms into percentage of total body surface area burnt. Whatever you calculate, it will be considered as one portion. It will be considered as one portion, right? So we have our patient who will take it as example. So we have 30% of the total body surface area burnt, and the patient is weighing 70 kilograms, right? So this was the data that we had. So we're going to calculate the amount of colloid that is going to be required to resuscitate this particular patient. 30% of total body surface area burnt in a 70 kilogram patient. So when you look at this, you have 0.5, which is here. So 0.5, weight is going to be 70 kilograms into percentage of total body surface area, that is going to be 30. So how much you're going to get? So 3 into 7 is 21, that is 2100. 0.5 is half of that, that is going to be 1050 ml of colloid. Now this 1050 ml of colloid, whatever you have calculated, is now what we call it as one portion of the colloid that you have calculated, and colloid should be given only for 36 hours. So what I'll do is this 36 hours of colloid resuscitation that we have planned. Now I'm going to split them into 3 equal divisions, that is 12 hours each. So you have 3 12-hour segment for the colloid resuscitation. Now this is your first 12 hours. This is your first 12 hours. This happens to be your second 12 hour, and this is the last, that is the third 12 hours. So according to the Muir and Barclay formula, if you want to resuscitate the patient, the colloid should be given when you look at the first 12 hours. You can give every fourth hourly. So every fourth hourly, that means I can give one portion every fourth hourly in the first 12 hours. How many portions can I give? I can give 3 portions. What is a portion? The amount of colloid that you have calculated. No, they required, this is called as one portion. So I can give 1 liter every fourth hourly for the next 3 consecutive points. That means for the first 12 hours. In the second 12 hours, I will give every 6th hourly, so I can give 2 portions. And the last 12 hours, I will give only 1. So this is the protocol which is called as the Muir and Barclay protocol. So I have divided the total colloid resuscitation into 36 hours, and that 36 hours is divided into 3 12 hours each. The first 12 hours of the colloid resuscitation can be given every 4th hourly. So maximum you can give 3 portions in the first 12 hours. In the second 12 hours, you can give maximum 2 portions, and the last 12 hours, you can give only 1 portion. This is how you're going to look for the colloid resuscitation, right? Now, all these are going to be quite important when you're looking at the entire resuscitation protocols. So we started the resuscitation protocol with the ATLS formula. We looked at how the ATLS formula has been designed based upon the percentage of the total body surface area burnt, and you look at how a complete fluid is being calculated. Okay? Right, so to summarize, in the ATLS division that we have looked for, so according to the ATLS protocol for burn fluid resuscitation, the first degree burn would only require oral fluids, and the patient can be sent home as well. Now, if it is a second degree or a third degree burn, and if it is an adult, then it is going to be 2 ml per kg per percentage of total body surface area burnt, and the expected urine output. In order to see the experts, I'll just look at the urine output that you're targeting here. The urine output in adults should be at least more than or equal to 0.5 ml per kg per hour. This is the targeted urine output. If the urine output is less than this, then you have to probably increase the resuscitation. If you have a child for a second or a third degree burn, then it is going to be 3 ml per kg per percentage of total body surface area burnt. In children, we'll target the urine output to be as more than or equal to 1 ml per kg per hour. The last one that you have is a fourth degree or an electric burn. A fourth degree or an electric burn, let it be an adult or a child. Here we have maintained that it is going to be 4 ml per kg per percentage of total body surface area that is burnt. So here the urine output that is targeted is more than or equal to 1 to 1.5 ml per kg per hour. One additional point specifically when you talk about the electrical burns. In the electrical burns, rather than the urine output per se, I need to target to get a clear urine. The target here is to achieve clear urine because whenever there's an electrical burn, there will be a muscular disruption that is causing myoglobinuria, right? And that myoglobinuria will result in that myoglobin to get accumulated in the loop of Henle, usually in the nephrons, resulting in acute tubular necrosis. In acute tubular necrosis, the patient will start producing dark colored urine. So presence of dark colored urine indicates the presence of there is myoglobinuria. So you have to give more fluid so it flushes it out, and that fluid resuscitation will be continued until you get a clear urine. It's as simple as that. The target is quite simple. You need to have a clear urine for your electrical burns. Okay? So this is what we summarize you for the ATLS protocols. Okay? So this is how you're going to look at the post-burn resuscitation for both crystalloids as well as colloids, a very, very important topic. Clear? I hope everybody's clear with this. Chalo. Now if you're clear with this, a couple of, just for the sake of understanding, when you look at the cause of the burn and the potential depth it can cause. We look at the cause of the burns and the probable depth it can achieve. Probable depth of injury that it can cause. Number one, it is hot water, that is scald. Scald burns are usually superficial burns. They are usually the superficial burns. Sometimes if the water stays for longer duration, it can also have deep dermal. But usually it is superficial, right? Now the second one that you have is going to be a fat burn. Fat burn is going to be oil and all that. In fat burn, it is usually a deep dermal burns. This is usually going to be a deep dermal burn. Then you have direct exposure to the fire itself. We call it as the flame burns. In the flame burn, we usually have, if you look at it, it is deep dermal, more common when compared to full thickness. Full thickness will only have if there is a longer duration of contact. So it is deep dermal when compared to full thickness. That is for your flame burns, right? Then you have alkali burns. Now alkali burns are usually associated with, when you look at the alkali burn, it causes liquefactive necrosis. Now liquefactive necrosis is going to result in deeper association. So that is why it is usually associated with full thickness burns. It is usually associated with full thickness when compared to deep dermal. It is usually going to be associated with full thickness when compared to deep dermal burns. Next you have the acid burns. The acid burns are associated with coagulative necrosis. They are associated with coagulative necrosis. So the necrotic, see the minute it forms the coagulum or the coagulative necrosis, that itself acts as a barrier and won't allow the acid to penetrate into deeper tissues. So hence usually it is going to be superficial to deep burns. So it is usually superficial when compared to deep dermal. Usually it is superficial when compared to deep dermal. Electrical burns is going to be a full thickness. The electrical burns are usually an involvement of full thickness. It is going to be a full thickness, right? So this is in terms of the various burns, causes, and the depth that it can cause the penetration into, right? Now, when we talk about the burn dressings and all that, we'll be talking about one of the important aspects, that is your topical dressings or the topical agents that we can have. So we'll be discussing quickly on the burn wound management. See, in a burn wound management, the concept is quite simple. If it is a smaller area of burn, you can go ahead with open method, put a topical agent and leave it. If it is going to be an extensive area, you have to cover it with either with skin grafting or flap, whichever component is required. You have other materials which are, the bioprosthetic materials which are available. They are evolving, but again, there are discussions for another day for it. So we'll stick to our basic burn wound management with the topical agents. So whenever I'm choosing a topical agent, the criteria for choosing a topical agent for the burns, I will see its effectiveness against Pseudomonas. Now, Pseudomonas is the most common organism. The Pseudomonas is the most common organism responsible for burn wound infection. Then we look for the gram-negative bacteria. We look for the gram-negative bacteria, its ability to penetrate eschar. Eschar is that fibrotic tissue that is formed over the burnt area, right? And obviously, does it cause any specific side effect? Does that topical agent cause any specific side effect? So this is the criteria that you will be looking at in the topical agent that we are going to choose, right? So look at the topical agent. The first one that you have is going to be a 1% silver sulfadiazine. It is 1% silver sulfadiazine. Now the good thing about the silver sulfadiazine that it is going to be extremely effective against Pseudomonas as well as gram-negative bacteria. It cannot penetrate eschar. So if there's an eschar, this agent is going to be useless, and there are no specific side effects. That is why this is now considered to be as the most common topical agent that we usually prescribe to our patients for the burn wound management. Now, apart from silver sulfadiazine, another that you have is going to be your silver nitrate. Now look at the silver nitrate. It has got a very good action against Pseudomonas. It has got decent action against gram-negative. It cannot penetrate eschar. Problem with that, it results in blackening of skin. See, the burn itself is cosmetically deteriorating, and then you give an agent which is further adding on to the cosmetic issues. So hence the patient is not complacent and the patient is not happy with this. So hence we don't usually prescribe. You can still give it, but again there's a cosmetic problem with this. That is a silver nitrite. Then you have another one which is called as the mefenide acetate. So when you look at the mefenide acetate, the mefenide acetate has a very little action against Pseudomonas and gram-negative bacteria, but it can penetrate eschar. The problem is, while applying the mefenide acetate, it causes severe pain. So patient will not like it because it will cause a lot of burning sensation. More importantly, rather than pain, it also causes metabolic acidosis, right? The patient of burn is already in metabolic acidosis. We have already discussed the reason. And now, while putting a mefenide acetate, it worsens it. So hence, mefenide acetate is no longer considered or used, even though it has got the ability to penetrate eschar. So we had to come up with an idea or a newer agent which can have a combination of all that. So hence, we have the fourth one, that is your silver sulfadiazine. It is silver sulfadiazine with cerium nitrate. With cerium nitrate, it is extremely effective against Pseudomonas as well as gram-negative bacteria because of silver sulfadiazine. It can penetrate eschar because of cerium nitrate, and there are no specific side effects. So if I say which is the best topical agent, So currently the best topical agent that you can consider for your burn wound management is going to be your silver sulfadiazine with cerium nitrate. Right? So this is how you're going to manage your patients of burns on the basis of topical agent, and this is the criteria on which you're going to choose the topical agents. Clear? Right? So this is all in all that you should know in the context of the topical agents in view of burn wound management. In the context of burn wound management. Clear? Right? So this completes your entire discussion on burns as well. So we spoke about what to look up in burns, how do you manage burns, and what are the topical agents, what are the criteria, fluid resuscitation protocols, crystalloids, colloids, everything we have dealt in this discussion of burns, right? So I hope it was a useful discussion. So next time when you're reading burns, just go through this. This is going to be a primary sketch of what you're going to read in Bailey. Everything we have tried to cover it. Yes, you might find, one or two more additional points that you can go read it. But yes, that is going to be our goal. You are going to refer this lecture as the basis of constructing a concept and then reading all the topics in Bailey, and we'll make sure that when you start reading it, there'll be a few other additional points that you will also see, but make sure you rewatch this video before you read burns, right? So thank you so much for joining. So that's it for today. We'll resume back tomorrow again at 9 p.m. So from tomorrow 9 to 10 p.m. we'll take rest of the trauma part which is left, like small ones. We'll talk about renal trauma, we'll talk about pancreatic injuries, we'll talk about small whatever topics ipsy are left in the trauma which are not that significantly important. I'll touch upon tomorrow, and tomorrow we'll wrap our trauma session, right? With that, thank you so much for joining. See you guys. I will reach you back tomorrow, and you know where to reach out. If you have any questions, any queries, you can reach out in the Instagram page, that is the surgery guy. This is both Instagram as well as Telegram. It is by my name, called as Dr. Sandeep Seeram Reddy. So watch out for this. Any questions, any queries, do reach out at this particular channel. Okay? So this is our Instagram as well as Telegram. Any questions, any queries, just DM me there and you'll find the answers. Thank you so much for joining. We'll resume back tomorrow at 9 p.m. Good night.